Okay, so we're going to quickly go through tachycardias. So remember, as a quick recap, and this video is on narrow complex tachycardias. So as a quick recap, we're going to just quickly remember the arrhythmias. So we have a brady, which is less than 60. And we have a tachy, which is greater than 100. Brady is bullshit, which is either a block or a sinus issue. If it's a sinus issue, it's sick sinus syndrome, tachybrady syndrome, requiring a permanent pacemaker, or sinus bradycardia, which is often nil issue. You could give atropine if it's particularly bad. AV block, there are 4 types, first, second and third degree, of which second degree is Mobitz type 1 or 2, depending on if it's a Linky-Beck's phenomenon or not. And then we have the BBBs, right and left, so unifascicular, bifascicular or trifascicular blocks. Tachycardia is divided into whether it's narrow or broad complex. If it's narrow complex, the issue is not in the ventricles. If it's broad complex, that implies that the QRS is elongated. QRS is propagation of electrical activity through the ventricles, so it's a ventricular origin of the problem. So this is the remit of this video, tachycardia. In particular, narrow tachycardias. So we know that it's not ventricular, and not only do we know that it's not ventricular, but we know that the QRS is okay, so obviously it's not ventricular and it's over 100 beats per minute. So these narrow complex tachycardias, let's give them a name. So atrial fibrillation, AFib, AFlut, A-flutter, AVRT, or Wolff-Parkinson-White syndrome, atrioventricular reentrant tachycardia, and atrioventricular non-reentrant tachycardia. We'll pair those little things together. You could have a premature atrial ectopic as well, and that is, you could have sinus tachycardia. Let's have sinus tachy. Now, we're not going to talk about sinus tachycardia because that is, the waveforms are completely normal, but rates over 100, and that's quite common, and is usually benign. Now, these little conditions, if I remember, I'll come back to them and summarise the treatment algorithms when we get there. So nil for this one. And any ectopics, the treatment's always the same. Remove triggers. So if you're getting palpitations paroxysmally, when you have a cup of coffee, avoid the trigger. If it's particularly bad, you can give them atropine. But, do you know what I mean? No, sorry. Beta blockers. What am I talking about? You can give them beta blockers if it's particularly bad. Pill in the pocket kind of beta blocker. So, atrial fibrillation is what, you could talk about this for a very long time. AFib, but let's keep it simple. So etiology and pathophysiology, it usually originates as a foci of aberrant electrical pacemaker activity causing about 120 to 180, depending on the textbook you use, beats per minute. Okay, the causes, we're going to use the mnemonic PIRATES, which I didn't come up with sadly. That's a pulmonary embolism, an infection, respiratory disease, good lord, respiratory disease, atrial enlargement, and that can be hypertrophy, or it could be an atrial myxoma, which is rare, thyroid, ethanol, and then sepsis and sleep apnea, all known to cause or exacerbate atrial fibrillation. So the clinical features will be palpitations, tachycardia, depending on 3 different strands. There are 3 different flavours of atrial fibrillation. Paroxysmal, persistent, and permanent. Paroxysmal, symptoms have occurred for less than a week. The treatment is usually, well, it's gone away in a week, so you're fine. You could give a short-term dose of beta blockers for rate control. Persistent and permanent, we're going to start to treat. So if it's lasted longer than a week, and indeed longer than a month, then we're going to start treating it. If it's lasted longer than a year, we're going to call it permanent. So if you've had AF for a year, it's likely you're always going to have AF. Okay? So, the investigations that you will see is you will see no P waves because the sinoatrial node is being completely overwhelmed by that aberrant foci, and the P wave is the sinoatrial node. You're going to see irregular QRS complexes because it's atrial fibrillation, which means jelly-like quivering. So the ventricles are quivering and they're contracting all over the place all the time. So it's just a wobbly QRS complex. And what you're going to actually see is something called an F wave. And an F wave is a fibrillatory wave, which is where the isoelectric line, so you've got your normal complex like this, and it should be quite smooth, but this is where your isoelectric line is kind of like this, so it's wiggly, and these F waves are what we see there. Now, the management of atrial fibrillation is complex. So you can break it down to, I've seen various different ways to describe it. I like to think of it with the 3 R's: rate, rhythm, and risk. So you need to control the rate because atrial fibrillation is fibrillating, right? So you're going to give beta blockers first line. If beta blockers fail, you can give digoxin off-label or diltiazem. You cannot give verapamil because a beta blocker plus verapamil combo can cause sudden cardiac arrest or profound bradycardia. Never give a beta blocker and verapamil, ever. Leave that shit to the cardiologist. So beta blocker with digoxin or diltiazem second line. For rhythm control, rhythm is a little bit of a different kettle of fish. So you're only going to go into these second line in persistent and permanent. So if the patient's had symptoms for more than 48 hours, you need to make sure that the INR is an appropriate level before you cardiovert these patients. So ultimately you want to do a DC cardioversion. Right? Direct current cardioversion to shock the aberrant pathways into what you want them to do. So if it's greater than 48 hours, you need the INR to be with 2 lux, 2 to 3. So 2 repeat attempts, you need 2 to 3. Okay, that's what you need the INR to be. So if it's greater than 48 hours, to get this INR to this level, you need to have the patient on 4 weeks oral anticoags to get to this level. After you've DC cardioverted this patient, you then need to have them for 3 months on oral anticoags after the cardioversion. If the patient is hemodynamically unstable on presentation with atrial fibrillation, or symptoms have been going on for less than 48 hours, you can just cardiovert straight away because there hasn't been enough turbulent flow for long enough. And we say 2 days is that cut-off window. If it's less than 2 days, you don't need to put them on oral anticoags, either a DOAC or a vitamin K antagonist. You don't need to put them on that. You can cardiovert them straight away. So let me just get rid of risk because we've run out of space there. I'll just summarise that. So if you've had for less than 48 hours, you can go straight into cardioversion. If it's greater than 48 hours, then we need the patient to spend 4 weeks on oral anticoags, where the INR on 2 occasions is 2 to 3. That's our target. At that point, we can cardiovert, and then they need to be on oral anticoags, either a DOAC or a vitamin K inhibitor, depending on trust guidelines, for 3 months. That's how you treat that. So we've done rate, rhythm, and now we need to look at risk. So if we're going to put a patient on anticoags, we need to do the risk. And the risk is our CHAD-VASc score, if you remember that one. So our CHAD-VASc score and our Hasbled score. So our CHAD-VASc score is CHAD-VASc. So CHAD, heart failure or coronary artery disease issues, hypertension, age 75 plus, diabetes, stroke or a TIA history, vascular disease, age 65 to 74, and then sex female. So if you get 1 score, then you need to put them on oral anticoags if they are male, and 2 oral anticoags if they are female. If you're going to put the patient on anticoags, you need to do a Hasbled score. So actually, I haven't told you what these mean, have I? So Hasbled is the risk of bleeding on anticoags, and CHAD-VASc is the risk of a stroke in a patient with atrial fibrillation. Whoops. So, Hasbled. Hasbled. This is H. My mind has gone completely blank. I'm sure you're screaming at the screen. Hypertension. A is abnormal renal function test or liver function test. S is stroke history. B is bleeding, so recent bleeding. Labile or unstable INR. Elderly, so over 65 or over. And then drugs or toxins. So for example, this is the bleeding risk on anticoags. So anything that could interact with warfarin, which is a hell of a lot of things, or they're already on anticoags or something similar, or aspirin, the kind. Any toxins that make bleeding more likely. The magic number here is 3. If it's 3 or more, then you need to watch closely, as the guidance says, because the risk is significantly raised. That doesn't mean don't do it, because you really don't want these patients to have a stroke. Whew, yes, so that is atrial fibrillation. You'll be pleased to know that's by far and away the most difficult one. So we've done atrial fibrillation, and it's the 3 R's: rate, rhythm, and risk control. Now, atrial flutter is a sawtooth pattern. That's what you classically see. So it's actually about 300 beats per minute. This is fluttering so much it's not even wobbling, it's just fluttering like a hummingbird. So about 300 beats per minute, depending on the text that you read. And I think it's a 3-to-1 ratio of atrial versus ventricular contractions. And so the consequence of this is these patients are a little bit different in how we go about managing them. So you're going to do a vagal maneuver. So you're going to upregulate the parasympathetic nervous system by pushing on the carotid sinuses, which will fool the body into thinking that the baroreceptors are sensing hypertension, not hypo, hypertension, which will upregulate vagal efferents to the heart. And that will reveal a sawtooth pattern on the ECG, and that's pathognomonic of atrial flutter. So it's a sawtooth baseline of the isoelectric line. And so if you see that in such a high rhythm, then you just do rate control, and it's the same as, so you just do rate control. So beta blockers first line, right? So rate control, so told you it'd be easier. So rate control. Now, AVRT is Wolff-Parkinson-White syndrome, so that bundle of Kent is a re-entry circuit from the ventricles to the atrium, so you've got a sort of circle current going on there. So literally, we just ablate. First line now, according to NICE Guidelines 2020, is we go in and we catheter ablate, we burn out that aberrant pathway, because it's a re-entry circuit that's causing all the problems, so we just ablate. Do not use calcium channel blockers or digoxin. So Wolff-Parkinson-White hates CDs, the old CD-ROMs, okay? Do not use those two because they augment calcium, which means that, remember that calcium prolongs the refractory period, okay? It prolongs repolarization, it prolongs the interval between action potentials firing. That's so important. We do not want, so do not give calcium channel blockers or digoxin, because if we do, then we're just ensuring that it's more likely that the bundle of Kent will fire and will make it worse. So AV-NRT, non-reentrant tachycardia, means it goes through the atrioventricular node as opposed to the atrioventricular septum. So we're going to do vagal manoeuvres, as we saw before, and then we're going to ablate. Ultimately, we'll ablate. Ablate for reentrant and non-reentrant tachycardias. We've already talked about those two. So those are the managements and a brief summary of the different types of narrow complex tachycardias.